video, we will discuss idiopathic orbital inflammatory disease. Idiopathic orbital inflammatory disease is also called non-specific orbital inflammation or orbital pseudotumor. It is a non-neoplastic, non-infective, space-occupying orbital infiltration with inflammatory features. It may involve any or all orbital soft tissues. Unilateral disease is typical in adults, although in children, bilateral involvement may occur. Intracranial extension is rare. Simultaneous orbital and sinus involvement is also rare and may be a distinct entity. Pathology. Histopathological analysis reveals pleomorphic inflammatory cellular infiltration followed by reactive fibrosis. Symptoms typically consist of acute or subacute ocular and periocular redness, swelling, and pain. Systemic symptoms are common in children. Signs. Pyrexia may be present in up to 50% of children, but is rare in adults. Congestive proptosis, mild to severe ophthalmoplegia. Fundus findings are seen if the inflammation involves the posterior orbit. There may be optic disc swelling. Choroidal folds may be present. Reduced vision should raise suspicion of optic neuropathy. Course of the disease. The natural history of the inflammatory process is very variable. There can be spontaneous remission after a few weeks without sequelae, or intermittent episodes of activity, usually with eventual remission, or severe prolonged inflammation, eventually leading to progressive fibrosis of orbital tissues, resulting in a frozen orbit, characterized by ophthalmoplegia, which may be associated with ptosis and visual impairment caused by optic nerve involvement. Investigations. CT shows ill-defined orbital opacification and loss of definition of contents. Biopsy is generally required in persistent cases to confirm diagnosis and particularly to rule out neoplasia and systemic inflammatory conditions. A wide range of other investigations may be considered to aid in the exclusion of alternative diagnosis, particularly infection, lymphoma, and non-neoplastic infiltrative diseases such as sarcoidosis and Wegener's granulomatosis. Treatment. Observation for relatively mild disease in anticipation of spontaneous remission. NSAIDs like ibuprofen are often effective and be tried in mild disease prior to steroid therapy. Co-prescription of a proton pump inhibitor should be considered. Systemic steroids should be administered only after the diagnosis has been confirmed, as they may mask other pathology such as infection or Wegener's granulomatosis. Oral prednisolone is initially given at a dose of 1 to 1.5 mg per kilogram per day, subsequently being tapered and discontinued over a number of weeks depending on clinical response. Further treatment may be needed in the event of recurrence. Orbital depot steroid injection may be useful in some cases. Radiotherapy may be considered if there has been no improvement after 2 weeks of adequate steroid therapy. Even low-dose treatment may produce remission, though much higher total doses may be necessary. Other options, usually as supplementary treatments or in resistant cases, include cytotoxic drugs such as methotrexate, azathioprine, calcineurin inhibitors such as cyclosporin, tacrolimus, and biological blockers. Surgical resection of an inflammatory focus may be contemplated in highly resistant cases. To summarize, idiopathic orbital inflammatory disease is a non-infective and non-neoplastic, painful inflammatory orbital disease. It is often unilateral in adults. CT shows ill-defined opacification. The disease is steroid responsive and is a diagnosis of exclusion. Biopsy may be needed if the disease is atypical or persistent.